Hi, and welcome to the presentation of Group 3. In this video, me and my team members will talk about a video laryngoscope device. But first, let me tell you what laryngoscopy actually is. Laryngoscopy has been a primary procedure to control the airways of patients during endotracheal intubation. And with the help of a laryngoscope, an endotracheal tube can be guided through the vocal cords and inserted into the patient's trachea. In patients with difficult airway characteristics, such as limited mouth opening or a large tongue, no clear view of the vocal cords and glottis is possible. And with no clear view, the endotracheal tube can also be inserted in the esophagus. Esophageal intubation can be very dangerous, as it's associated with desaturation, increased risk of aspiration, and even cardiac arrest. To encounter these difficult intubation, a video laryngoscope, also called a VL, is used. With video laryngoscopy, an incorporated camera allows for real-time visual guidance on screen during endotracheal intubation, and therefore you can see the navigation of the endotracheal tube through the vocal cords and prevent esophageal intubation. In this video, the exact procedure can be seen. Despite the advantages of VL and the fact that difficult intubation occur at least as often and probably more often in low to middle income countries in comparison to other countries, its price does not allow the technology to become an established practice in low and middle income countries. So this is also a problem statement. Video laryngoscopes are not affordable for use in hospitals in low to middle income countries. The owners of Delscope have developed a video laryngoscope in an affordable manner, which makes it available for low and middle income countries. Their requirements were that it had to be robust, easy to maintain, and easy to clean with as little components as possible. The Delscope connects a low-cost USB endoscope to a smartphone and consists of a 3D printed housing and camera holder, on which a real-time visualization of the airways is displayed. This alternative allows for the advantages of a VL while avoiding its high cost. But there are several design requirements, of course. Functional performance and safety requirements that a video laryngoscope should meet before it can be brought to the market. And some of these requirements the Delscope have already met. But when developing a VL to be used in low to middle income countries, additional requirements may come. And one of the main functional requirements that should be met with their new design is that the laryngoscope has to be affordable enough for hospitals in low to middle income countries. This can be achieved by keeping the manufacturing costs as low as possible, by using a suitable but cheaper alternative material, and by keeping the design as simple as possible. One of the important performance requirement is that the design should include an ergonomic smartphone holder. Even if it seems contradictory with the requirements mentioned above, including an ergonomic design of a smartphone holder can be beneficial for anesthesiologists in low to middle income countries. Often they have less experience with VL. Including an ergonomic smartphone holder with a fixed angle ensures the avoidance of unnecessary head movements by the anesthesiologist in other directions than of the patient, and therefore increases the chance of successful intubation. The most important safety requirement that is applicable to the new design is that the lumen and outside of the VL should be compatible with the disinfectant Sidex. Sidex is a commonly used disinfectant worldwide and is also used in hospitals in low resource countries. Therefore, it is of importance that the new design should be compatible with Sidex. All of these requirements need to be taken into account when selecting the materials for the laryngoscope. Here to tell you more about this is Justin.
All right, thank you, Leek. So just to reiterate, the key considerations made when choosing the material includes that the material must meet the minimal functional requirements. So that includes the stiffness of the material. It must be 3D printable. It must be affordable, seeing as our customers are in low to medium income countries. It must be compatible with Sidex, and the material may not degrade significantly enough to fall under the minimal functional requirements during the product's lifespan. So although the original material considered for the Delscope was a PC-ABS blend, a literature study revealed that the slightly more expensive but also readily available PC-PBT blend is more resistant to embrittlement when put under a constant strain while being submerged in aggressive disinfectant for a 24-hour period. This increase in chemical resistance means that the 3D printed components of the laryngoscope can go through more disinfection cycles without losing their mechanical integrity. And the increased lifespan therefore offsets the slight increase in cost associated with this material choice. For the manufacturability, a flowchart was made to outline the most important checkpoints. The PC PBT blend is ordered from a third party and printed into the design pieces. Like the PC PBT blend, the USB endoscope is also ordered from a third party. And as indicated by the stop and go symbols, batch testing is used throughout the manufacturing process for quality assurance control. The third parties involved in the process are required to provide proof of conducting batch tests in regular intervals. Next is the assembly, which consists of gluing in the lens and packaging all the individual components of the laryngoscope. Again, batch tests are conducted to ensure the quality of the final product. Following the packaging, the laryngoscope is shipped to the customers in the low to medium income countries. After this, the communication between us and the client is not over. Should the customer encounter any problems, the source of the problem will be identified and the appropriate steps taken to eliminate the problem, as shown by the feedback loops in the chart. All in all, manufacturing is a complex series of processes, and mistakes, whether intentional or not, can result in risks and harms to the patient. And here to give you more insights into the specifics of these is Lise.
Now that we know how we are going to manufacture the Delft scope, it is important to get a sense of the possible dangers and risks along the route. When designing a medical device that you want to have CE certified, it is important to keep track of all possible misuses and risks. To do so, we set out the entire process from manufacturer to disposal. In each step, we identified all possible misuses. For the intended purpose of the device, we focused on risks and hazards, and we also identified some harms. I will only go into the risks and hazards, as the harms are a result of the hazards and are too detailed for this presentation now. In total, we were able to identify 12 types of risks, many of which could occur more than once throughout the process. Some risks will only come up in video laryngoscopy and not in direct laryngoscopy. An example of this is risk number 4, where the intubator gets distracted by the use of the monitor for his orientation and thereby is not focused enough on the intubation itself. This could result in damage on the patient. An example of a risk that is specific to our laryngoscope is risk number 10, where the smartphone application will crash and the intubator will lose his line of sight and will no longer know where exactly he is working. This will also possibly result in harm to the patient. Now that we've identified all the risks, we were able to rank these. We did so on the probability and the severity. The probability is on how often this would happen, and the severity had to do with the effects of the risk occurring. We were also able to draw a line and see what risks we would consider unacceptable. These are marked in the red boxes. Eventually, we were able to identify 2 unacceptable risks. Although other risks are ranked as acceptable, that does not mean that nothing should be done with them. Each risk brings along another problem and therefore must always be considered when redesigning the device. After redesign, it's also important to reconsider all the risk assessments and see if something has changed here. Now that we know what the risks are and what the possible consequences are, we can look into how we can minimize these risks. According to the ISO 14971 appendices, we can do this in three ways: inherent safety by design, protective measures in the device, or information for safety. To get a better sense of how urgent the risk is, a semi-quantitative analysis is necessary. To be able to do this, we would need a good quantification of risks. Therefore, it is important that all investigations and clinical evaluations are done properly, so that we can fully assess all the risks. All in all, to assure the safety and minimize as many risks as possible, more clinical evaluations are needed to find the bottlenecks in the current redesign of our Delft scope. Additionally, as many risks as possible should be quantified to map out where the design lacks in safety measurements. One way to reduce risks is by redesigning the device, And Bo will now present to you how we've redesigned our Delft scope to improve patient safety.
As stated by Lies, we have made some design modifications in comparison to the original design of the Delft scope. The proposed redesign is focused on minimizing the risk of accidental disconnection of the wire connecting the USB endoscope and the smartphone. The current design proposes a long cable to make it possible for others to hold the smartphone. However, this may lead to entanglement of the cable with other objects in the operation room, which subsequently can lead to pulling on the cable and to disconnecting of it. Furthermore, this can also lead to faster deterioration in function of the cable. To minimize the risk, a phone holder will be added to the design. This adjustment will also make sure that the phone and mouth will be better aligned, which allows the anesthesiologist to better divide his or her visual tension between the phone and the mouth. This can subsequently decrease the risk of soft tissue damage caused by the absence of either indirect or direct visual feedback. The phone holder will consist of a flat surface, which is directly connected to the tip of the handle of the laryngoscope. The phone can be placed upon the surface, and the position of the phone will be secured by an elastic band, which wraps around the phone and phone holder, as can be seen on the two images on the left. By using two hooks, the position of the elastic band can be secured. Originally, two other iterations of the phone holder were proposed. The first iteration, as can be seen here, was a phone holder with adjustable arm extensions, but the design increased the number of parts significantly, added moving nuts, and had extra ridges and nudges, as can be seen here in the red circles, which decreased the cleanability of the entire device. The second iteration tried to make the first iteration more cleanable. However, it failed to do so as it introduced sharp edges and still contained too many parts. Furthermore, it always needs full disassembly before it can be cleaned, which is of course a major disadvantage when having this many parts. The last iteration, which was the final design, improved the cleanability by decreasing the number of parts to 2 parts and subsequently decreasing the amount of moving parts, ridges, and nudges. Nevertheless, the elastic band may introduce disinfecting and sterilization problems, which need to be further evaluated before finalizing the design. Now that we have the final design, the question arises where we are in the route to CE marking, which Farah will inform you further about.
And now I'm going to zoom in on the flowchart that shows the route to the CE marking. So our redesigned VL is currently at the first step, which is the classification of the medical device. And in the flowchart, we have marked this stage with a yellow warning sign. So it has been decided that the VL is a Class 2B device. The next step will be the conformity assessment and technical documentation. However, important parts of the technical documentation, as for example the general safety and the performance requirements, need more elaboration. And other parts, such as the preclinical and clinical data, are even missing. And also for the conformity assessment, we need a final and complete product. And when looking at the current state of the device, data and information is still being collected and optimized. So currently we're not ready to do these assessments, and that's why we have decided to put the medical device at this stage in the flowchart. So in a later stage of the CE marking route, the safety of the medical device and the claimant benefit should be proved. The first clinical evaluation study should be focused on the comparison of the Delft scope versus the direct laryngoscope. However, it is important to note that the recommendation of putting the redesigned Delft scope on the market does not solely depend on the clinical evaluation of the Delft scope versus the direct laryngoscope on difficult to intubate patients. To fully show the added value of the Delft scope in low to middle income countries, clinical evaluation of the use of the Delft scope of experienced versus inexperienced anesthesiologists should be performed. So this was the end of our presentation about our redesigned VL for low to middle income countries, and we want to thank you for your attention.
Woo!